can't see it. Just pretend. These are good outtakes.
Hi, Mr. O'Connell. How are you today?
I'm good.
Anything bothering you since your last visit?
No.
Awesome. So we're going to finish off your head to toe assessment for your annual physical. Have you had any indigestion, acid reflux, or abdominal pain since your last visit?
No.
All right, so let's start with the abdominal portion first. I'm going to have you have your head lying there and just lay on the table very carefully.
Okay.
You're a very tall individual.
Oh, okay.
All right, and is it okay if I just lift your shirt up just for the purpose of the examination?
Yeah.
Thank you. All right, so first I'm assessing the abdomen. The abdomen looks to be normal in color. There's no lumps, there's no lesions or visible hernias from what I can see, and there's no distension. So the next thing that I'm going to do is I'm going to pretend that I have my stethoscope on me. And I'm going to listen or auscultate my 4 quadrants. 1, 2, 3, 4, and I'm just listening for bowel sounds. So the patient appears to have normal active bowel sounds. There's no hyperactive or hypoactive bowel sounds, and there's absolutely no absence of bowel sounds, which is always good. The next thing that I'm going to do is I'm going to auscultate for the abdominal aorta, which is approximately 2 fingers above the umbilicus. I'd put the stethoscope here and I would listen, which I hear. While I have my stethoscope in hand, I'm also going to listen to my iliac veins as well as my femoral veins. So my iliac veins are 2 fingers away from the umbilicus. I would listen. And then my femorals would be down here. Which all seem to be present on the patient. The next thing I'm going to ask my patient to do is just sit ever so slightly upright as if you're flexing your abdomen. Excellent. And I'm going to look for the rectus muscle to be midline, which it is. I'm also going to look for any hernias or any possible lesions or masses, which there is not. You can relax down. All right, so the next thing that I'm going to do is I'm going to finish with percussing. Just put your arms right down to the side. Perfect. So I'm going to take my 2 fingers and I'm just going to percuss. So what I'm listening for is for there to be any dullness. If there's dullness, that usually means that there's either fluid in the cavity or an organ, but mostly he has hollowing, which is excellent. That just means that there's air. The next thing that I can do is I'm going to percuss for my liver. So I'm going to go to my right side, no, my left side, and I'm going to go diagonal towards the costal margin. Did I say liver or spleen?
Liver.
Oh boy, my spleen. So once again, on the right side, I'm listening for my spleen, just below the intercostal margin, which I hear dullness, so that's the spleen. And then for my liver, I'm going to go to the right side, right? Oh my God. I'm going to go to my right side, and I'm going to go directly up towards midclavicular line. And it should be dull. While I'm doing that, I'm just listening for any potential enlarging of the liver. Good. So the next thing I'm going to do is I'm going to palpate. I'm going to start with a light palpation. I'm also going to look at my patient's face while I'm doing my palpation, just to see if there's any grimacing, any pain or tenderness upon palpation. Any pain when I press?
No.
and the abdomen is soft, it's non-tender, not feeling any distension, and the patient is nice and relaxed. Next thing I'm going to do is my hard palpation. Any pain?
No.
And once again, I'm just going along the abdomen. I'm just trying to feel for any hernias, any masses, paying attention to my patient's demeanor. Good. So now I'm going to go back to palpating my internal organs. So I'm going to start with my spleen. Once again, 2 fingers away from the umbilicus. On the, I can't tell my sides apart, on my left side, and directly across from my my intercostal space, and palpating the spleen does not feel to be enlarged. Now I'm going to go on my right side, 2 fingers away from the umbilicus. I'm going to go over midclavicular line towards my sternal notch. If I'm having difficulty, I can always percuss again, just to find the outline of my liver, which it does not appear to be enlarged. For my kidneys, what I'm going to do is I'm going to take my hand, I'm going to press it underneath my patient, and I'm going to ask them to take a deep breath in, and as I take a deep breath in, I'm going to press down and slowly let out. I'm going to release. It's always harder feeling the left side of the kidney. Can't really feel it, but we can do it on the right side. So once again, I'm just going to put my hand underneath. I'm going to ask my patient to breathe in. As he breathes in, I'm going to press down. And I should feel the kidney kind of slide over. It should be smooth, firm, and non-tender. All right. Actually, one last thing is I'm also just going to palpate the bladder. Any pain or tenderness when I palpate?
No.
And the bladder appears to be soft and non-tender. It's not distended. Have you had any difficulty with urination?
Nope.
Perfect. All right. Ever so carefully, you may sit up. So for the next portion of this exam, we're going to focus on the upper body. I'm going to look at his skin. His skin is clean, dry, and intact. There doesn't appear to be any discoloration, any cyanosis, any pallor. There seems to be no abrasions, any significant lumps or lesions or masses that appear to be present in the body, which is always good. So the next thing I'm going to do is I'm going to basically just sit upright for me.
Mm-hmm.
Thank you. So I'm just going to feel for my clavicle. Making sure that connects. I'm going to feel for my scapula back here. Any of this tender when I palpate?
No.
Good. I also want to make sure that everything appears to be midline, which it is. Feeling for his sternal notch. His xiphoid process. Now I'm going to come back over to the other clavicle. Connects very nicely into our insertion point. Feeling the back by the scapula. Once again, no tenderness or pain?
No.
Excellent. What I'd like for you to do is just shrug your trapezius muscles up and down, up and down. Good, so that seems to be intact. Excellent. So once again, both sides are symmetrical. These xiphoid process and the sternal notch are midline, and there doesn't seem to be any pain. Also, while I'm here, what I can do is I just can assess my insertion points. No pain or tenderness?
No.
Excellent. And again, on the other side, I notice here that you had surgery. How long ago was your surgery?
2 years ago.
2 years ago. And what did you have done?
Rotator cuff and bicep tendon.
That seems to be very painful. So there's a little bit of scarring from the laparoscopic surgery. All right, the next thing that I'm going to test is basically my range of motion. So what I would like for you to do is lift your arms over your head like you're creating a rainbow. Any pain?
No.
Good, and down. Now I want you to give yourself a big hug with your arms crossing your body.
That's not really just.
A little bit of stiffness noted, excellent. Good. So now I'm gonna have you bring your arms midline, and I'm gonna have you flex, like you're lifting up bicep, like you're doing a bicep curl. Good, and down. And now I'm gonna have you wrap your arms around your back. Good, and come out to the side, and palms up, palms down, palms up, palms down. Now I'm gonna have you bend your arms, and bring your arms up, and down for internal and external rotation. Up and down. Excellent. You can relax. Next thing I'm going to do is I'm just going to palpate my elbow and my olecranon process, which is the nice little bony prominence in here. Any pain?
No.
Good. I'm just going to have you bend your elbow. Good. Any pain?
No.
Good, now bring your arm like this. And I'm just gonna have you do your pronation and supination. Pronation and supination. Excellent, can you repeat that on the other side? Good. Pronation and supination. Good, and then just bending your elbow again.
This way?
Good, and excellent. Good, and bring it down. Once again, just palpating his elbow and the olecranon process. Excellent. Now for his wrist, I'm gonna have him turn his wrist up, and I'm gonna feel for any type of cysts. Any pain or tenderness?
No.
Excellent. No cysts or masses. So I'm here, I'm also just gonna feel for my radial pulse, which is +2. And then my ulnar pulse. Radial pulse, +2, nice and strong. And then my ulnar. Excellent. All right, so next I'm gonna have you do with your wrists is you're just gonna put them out directly in front of you and lift up, lift down, lift up, lift down. Then we're gonna do our abduction, adduction. So turn them to the side, in, out, in. Excellent. So he's got excellent range of motion, no stiffness. Next thing that we're gonna test is for our reflexes. So I'm gonna do my bicep first. So I'm gonna ask my patient if I have difficulty finding my bicep tendon. I'm gonna ask them to kind of like make a flex for me. Good. Next thing I'm gonna have you do is just relax. I'm gonna feel for the cord. And basically what I'm gonna do is I'm gonna strike the tendon and I'm gonna feel for a contraction in his bicep and a flexion in his forearm. 1, 2. Good. And one more time. 1, 2. Excellent. And I would repeat the same on the other side. For purposes of time, we're not going to do that. Next thing I'm gonna do is my tricep. So I'm gonna ask my patient to just bend. Good, and what I'm looking for is a flexion of the tricep and an extension or flexion of the forearm. Good, just relax your arm. this arm should move ever so slightly. It's just hard to get in the right spot. Good, we'll do it one more time. Excellent, and just rest down. So the next thing that we're gonna do is the brachial radius. So with your hand, basically I'm gonna feel for the styloid process, which is approximately the little bumpy ridge here, and I'm gonna do 2 fingers above it. That should be my brachioradial tendon. And what I'm looking for is for his palm to almost kind of like jerk a little bit upwards. Okay, relax your hand, let it go limp. Good. Good, and one more time. Excellent. While I have my hammer in hand, I'm going to test his patellar reflexes. So what I'm going to do is I'm just going to put my hand ever so slightly, thank you, behind just the support. I'm going to ask the patient to just relax. And I'm going to feel for the little bony prominence above the patella, or below the patella. I can't talk. If you hit it in the right spot, it'll go out. Good. And I would do the same on the other side. For the Achilles, basically I'd have them dangle their feet. I would ask them to plantar flex. Sorry. And just right above the heel, I would strike it, and I'm looking for a dorsiflex. Okay, relax. Good. Excellent. All right, so I'm going to ask you to just lay on your side very carefully.
Right side?
Sure. Actually, you know what? Can you face the wall, please?
Okay.
For purposes of demonstration, just be a bit careful. That's what happens when your husband's 6'5". Anyway, okay. So next thing we're going to do is we're just going to palpate his hip bones. So what we want to do is we want to start by the iliac crest and make our way towards the trochanter. Everything seems to be intact. And then I would repeat the process posteriorly, feeling for my hip bone first, going down to my ischial tuberosity. Any of this hurt when I press?
Yeah.
Awesome. All right, so you may sit up nice and carefully again. Good. So next thing I'm gonna have you do is, I wanna do this.
Upstairs. Go upstairs. Go over there.
All right, so the next thing I'm gonna do, working my way downward, is I'm going to assess his kneecaps. And basically I'm going to palpate. I'm gonna feel for the patellar tendon. I can't talk, oh my God. Okay. Let's start again. 1, 2, 3, okay. So the next thing I'm going to do is I'm going to feel for the insertion of the So next thing I'm going to do is I'm going to palpate his knee.
Get the fuck upstairs. Get upstairs and shut up! Go upstairs and shut up. Fucking working, alright? Go upstairs now. Get the fuck out of there now. Go upstairs.
So next thing I'm going to do is I'm going to do an inspection of the lower half of his body. First I'm going to look for any asymmetry in bilateral kneecaps. I do notice a little bit of scarring on this one. Did you have prior knee surgery?
20 years ago
Okay.
on this one. 10 years ago on that one.
Oh, I see that they did this one laparoscopic,
Mhm.
and this one they looked like they ripped you open.
Yeah.
So next thing I'm going to do is I'm just going to feel for the insertion of the patella. Please don't, Lacey, please. I'm going to feel for the insertion of the patella. Any pain?
No.
And I'm also going to feel posteriorly, make sure everything's intact, which it is. Good. I'm going to do the same on the other side. Any pain?
No.
Good. And his legs appear to be normal in color. There's no swelling, no ecchymosis forming, which is always good. So the next thing I'm going to have you do is test kind of like your range of motion again. So I'm just going to have you extend this leg out. Good, and go back like you're doing a hamstring curl. Excellent, and extend this leg out. And once again, like you're doing a hamstring curl. Excellent. So that's testing extension and flexion. What I'm going to do is I'm going to have my patient stand up. So just stand for me, please. Nice and careful. I'm going to have you turn your back towards the camera. Good. So next thing I'm going to do is do my spine examination, looking and making sure that the spine is midline and both scapulas are symmetrical, which they are. Any pain?
No.
Excellent. And I'm just feeling for the spinal process. Good. I don't feel any abnormal lumps, lesions, or masses. Good. So the next thing I'm going to have you do is I'm just going to have you bend ever so slightly at the hip. And this just kind of helps me feel for anything that might be protruding. Good. Excellent. And just stand up. The other thing I just want to observe is to make sure that my arms are symmetrical when the patient stands up. There doesn't seem to be any deviation, so I don't think that there's any scoliosis or kyphosis forming, which is good. All right, you can turn. Excellent. So next I'm going to have you do, let's have you stand to the side. Perfect. So I'm going to test your range of motion. Best you can, just bend forward and touch your toes for me. Good, and then come up ever so slightly and just flex back towards me, best you can without hurting yourself. Good, and just go, good, stand upright and just go side to side. Good. And then I also want you to just bend to the side of the hips. Excellent. Any pain or discomfort?
None. Just tightness.
Just tightness. Do you see a chiropractor?
Yeah.
All right, good. So make sure you keep up with your chiropractor appointments. Also, you can do some anti-inflammatories just to help with the pain. Make sure you stretch. Also, ice and heat, rotating every 20 minutes on and off would help. I'm just gonna have you sit again on the table very carefully. So we're gonna test our neurological movements. Make sure our patient's coordination is intact. So the first thing that we're gonna test for is our RAM, which is our rapid alternating movements. So basically we're gonna play a game of Simon Says, just without the Simon saying. So we're gonna test our pronation and supination. What I'm gonna have you do is just put your palms on your knees. Good, and as fast as you can, alternate. Up, down, up, down. Excellent. Next thing I'm gonna have you do is as fast as you can, very carefully, just normally we would ask them to tap their toes on the examination table. I'm just gonna ask you to tap your feet together, like you're clicking your heels. Excellent. Last thing I'm gonna have you do is just touch your thumb to every finger. Perfect, so all of his coordination seems to be intact. The next thing I'm gonna have him do is do our heel to shin test. So I'm gonna ask my patient if we could just take your heel and drag it up to your kneecap, and then once again, all the way down. Excellent, just repeat on the other side, Jen, and all the way down. Perfect. So next we're going to do our exteroceptive sensation. So you're going to close your eyes and I'm going to touch you with different objects and you're going to tell me if it's a sharp feeling or a dull feeling, okay?
Okay.
So I'm using an L key and a little cotton swab for this test. All right. Tell me when you feel me touching.
Felt it.
Tell me when you feel me touching.
I feel it.
Do you feel me touching?
Yeah.
Feel me touching?
Yeah.
Good. Now I'm going to touch you again. You're going to tell me if the pain is dull or sharp. Okay?
Dull. Sharp. Dull. Sharp. Sharp. Dull. Sharp. 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 Sharp.
Mm.
Dull. Dull. Sharp.
Good.
Sharp. I can't tell. Sharp.
So it seems as though the patient has decreased sensation on the left side, the left lower extremity. That's interesting. Anyway, let's continue with our examination. The next thing that we're going to do is our proprioceptive sensation, where basically I'm going to spread the patient's fingers apart and I'm going to see if he can tell if I'm moving them up or down. So just close your eyes, put your fingers out, spread them, good. Am I moving your finger up or down?
Up.
I'm definitely doing it the wrong one because did you break that one? Where you sprayed it?
Oh.
Okay, oh God. We'll do the pinky.
Down. Up.
Good, and we'll do it with the other hand for purposes of time.
Up. Down.
Good. And essentially I would do the same on the feet just to make sure that the patient has full sensation of his feet. Just once again, spreading out the toes, either doing up or down with the patient's eyes closed. All right, so the next thing that we're going to do is we're going to use our tuning fork and you're going to tell me if you feel the vibration and once it stops, okay? So just,
again.
yeah, close your eyes. I need your hands though. Please, thank you. Do you feel the vibration?
Yeah.
Good. Feel the vibration?
Yeah. There. Yeah. There.
Good. vibration?
Nope.
Do you feel the vibration?
Nope. Yeah.
And did it stop?
Yeah.
Do you
Yeah. Feel it.
And did it stop?
Yeah.
Excellent. Gotta get that left side checked out, man.
No nerve
Oh, well.
feeling down the hole.
Things that we should tell our wife before health assessment. Anyway, the next thing that we're going to do is the sterganosis, where the patient is going to identify different objects that I placed in his hand. So if you would close your eyes again and put your hands out in front of you. No, yep, perfect. All right, so this is just patient identity. All right, so just close your hand and tell me what you feel.
Cotton ball.
A cotton ball, excellent. Keep your eyes closed and close your hand. What do you feel?
Like a coin.
A coin. Do one more time and close your hands. What do you feel?
Q-tip.
Q-tip, good. All right, so the next thing that we're going to do is our grasthesia, where we're going to draw different symbols that are familiar into the patient's hand, and they have to identify it. This is very prominent in the pediatric population. So keep your eyes closed again. I'm very boring. All right, and what letter am I drawing?
No clue.
We'll try an easier.
Try it again.
We'll try an easier one. All right.
I don't know what that is.
It's an S.
Oh, okay.
Let's try it on the other hand. I'm going to draw a number. Okay? A number.
6.
We'll try that one more time.
2.
A 2. Good job. Anyway, so we're going to do our 2-point discrimination test now, where patient's going to tell me if I'm touching him once or twice. So keep your eyes closed.
Okay. Sorry.
Once or twice?
More than twice.
No, one finger or 2 fingers?
1 finger. 2 fingers.
Good.
1 finger. 2 fingers. 1 finger. 2 fingers. 2 fingers. 1 finger.
Excellent. So the patient has equal sensation on both sides, and he's able to tell 1 to 2 apart. So the next thing that we're going to do is you're going to stand up ever so carefully without hitting the dog. And all I want you to do is walk to the couch and walk back in a nice straight line. Good. So I'm observing my patient's gait, making sure that he's nice and steady on his feet. Next thing I'm going to have you do is you're going to do heels up, and you're going to walk towards the couch, heels up. Good, and other way, heels up. Next, you're going to walk on your tippy toes. Good, and now I'm going to have you do the sobriety test where you do toe to heel and walk in a straight line.
What?
The sobriety test.
I never did a surprise test.
I haven't either, but that's what I see in the
Okay, so what do you have
TV
to do?
shows.
What do you have to do? Walk?
Toe to heel.
What's
Please.
toe to heel?
When you walk like this.
Oh.
In the
toe to
straight
heel.
line.
Oh,
Yeah, toe to heel.
Okay.
Oh boy.
Okay.
Okay. Alright. And back. Excellent. So the next thing I'm going to have you do is our Romberg test, where basically he's going to hold his hands out in front of him like a zombie, and he's going to close his eyes, And I just want to, once again, check for any type of deficits. This is very popular among stroke patients if there's a deficit or a gait imbalance, also with our vertigo patients. So you always just want to make sure that you practice safety, making sure that you're supporting the patient, making sure that there's something behind them, God forbid they fall. Excellent. And arms down at the side. So next you're going to sit. We're going to do that same exact action, except sitting. So it's called a pronator drift, where basically your arms are going to be out in front of you like a zombie. Close your eyes, and we're just going to look for any type of drift or deficit or weakness in one of the extremities. Excellent, which there appears to be not. Good. All right, other than that, do you have any questions for me?
No.
Excellent job.
Thank you very much.